Hey guys, James saying. So today's video is going to be focusing on if you're relatively new to the Cath Lab, what the day in the life of a Cath Lab is like, with a heavy emphasis towards medication. This also comes at the request of one of my followers, Shelby. Thank you for the request. So we'll take you through some steps as if a patient's coming into the Cath Lab and some things that you're going to think about, some of the medications that you're going to encounter. I can't cover them all because it depends on the exact situation. So, a day in the life of the Cath Lab, ACLS, and pharmacology perspective. So, now most people, when you come to the Cath Lab, when the patient comes to the Cath Lab, it's very important to know things about the patient. Now, you may have your STEMI coming in and you just asking the ED or asking the floor, did they get heparin, aspirin, what are they allergic to? We got to go. All right, so in this made up example here, we have a diagnostic cath on an 85-year-old male. He's 85 kilograms. History, previous MI, peripheral arterial disease, asthma, hyperlipidemia on a statin. Creatinine is 38, creatinine is 1.9, gives a creatinine clearance of 32, platelet counts 119,000, potassium 3.6, and his troponins have been positive so far. Times 3, he's allergic to shellfish, metoprolol, and latex. Okay, so that's a lot of information. You want to know some of these things as far as like the BUN and creatinine. Blood doesn't show up on x-ray, so the doctor's going to inject contrast, take x-ray pictures to see what the arteries look like, whether it's coronary, whether it's peripheral, and the kidneys will get rid of the contrast. So contrast can induce kidney failure or worsening renal function. So you do want to know, if you're doing something electively, if the BUN and creatinine, some physicians are going to focus more on creatinine, some are going to focus more on creatinine clearance. But if it's trending in the wrong direction, most people have, if it's above a certain level, you may not be doing the cath that day. Excuse me, so a physician's discretion. So it is good to know because you're going to give contrast, which is a medication. Now, you won't get to choose your cath lab's just going to use whatever contrast they use for coronaries, and they probably use a different contrast for peripherals, but still all cleared by the kidneys. Additionally, on here, we're looking at platelet count. You're going to poke holes in arteries, generally speaking, when you come into the cath lab. So you want to know, does the patient have the ability to clot their blood? And the platelet is an integral part of that. And we'll look at some other lab values as well. Potassium 3.6, you're going to be putting catheters in different chambers of the heart. If you're doing a right heart cath, if you're doing a left heart cath, you're probably going to the LV. Really high potassium, really low potassium, and a catheter in one of the ventricles equals, like VTAC, VFib. Troponins are nice to know. It's always good to know what's the patient allergic to. In this case, so the thing with shellfish is usually iodine-based. Contrast is iodine-based. Some physicians will say, oh, we're not going to give them any shellfish. Ooh, ooh, ooh. Okay, and then some physicians will say, well, yeah, we're going to go ahead and pre-treat them, typically with medications to prevent an allergic reaction. Continuing on, so most hospitals will have some type of cheat sheet. This is just the one we use at the hospital where I work. So here, made up patient John Smith. We're doing a left and right heart cath. There's his allergies. I'm not going to read all this again. I need to know his weight. He's 85 kilograms, and here, so he's got, I want to know PT, INR, and PTT. So he has a PT of 15.1. I really want to know INR, 1.9. Okay, well, different physicians will have their magic number, the INR being too high where they're not going to do a cath. It depends if that physician is doing femoral, a much higher risk of bleeding, or is he doing a radial approach, lower risk of bleeding. A lot of physicians have 1.8. That doesn't mean your physician's magic number is going to be 1.8. It also depends on the urgency of the cath. But you would like the INR to be less than, you like to be as close to normal as possible, but that's not always possible. But get 1.8, 1.9, starting to get in the 2s, the INR, that's really getting high. Really high risk of bleeding. PTT that usually goes along with heparin, or some hospitals are going to the antithrombin or anti-10A to check heparin levels. Sodium, potassium, glucose, their BUN and creatinine. Oh, look at that. I have an INR 1.9 and creatinine 1.9. It just depends, and I got a creatinine clearance of 32. So some medications that you're going to give, the creatinine clearance is 50 or less, you're going to adjust the amount of medication you're going to give the patient. So there are some drugs that worsen renal failure. You want to avoid those drugs. History. So when we get down here, this patient's COVID negative. I started making this back in 21, back in the COVID days. Surgical history, they've had bypass times 3. All right, what are you going to be hunting for bypass grafts? I always want to know the ejection fraction. They have an EF 25-30%. If this made-up patient probably not going to tolerate fluids too well. You don't want your fluids to get away from you. You may have your fluid on a pump. You may have your fluid on a dilaflow. I don't know. You may just have your fluid clamped off. You give your medication, open the fluid, flush it in, or you just may use a syringe to flush in your fluid. But don't let the fluid get away from you, especially if somebody has a low ejection fraction. You're going to put them in worsening heart failure. They are on the history. They have history. They're supposed to be on aspirin and Plavix. It was due at 9 o'clock in the morning. That's usually when most people give their AM meds. So I don't know what time. It's 4:15 right now. So they should have already had their aspirin and Plavix. Hey, it's good to know normals. This is a typo. Metformin 100 milligrams. Metformin is 1,000 milligrams. Well, what's the reason of that? Well, metformin plus contrast can lead to worsening renal failure. So most people are going to have their metformin held 1 or 2 days post-procedure. Some people will hold it pre, but most people hold it the day of and post-procedure. In this made-up scenario, the patient's on a heparin drip and a nitro drip. A lot of times you're turning off the heparin drip and you're picking up the patient, putting him on the table. Not always. It just depends what your doctor wants. Nitro drip, you're probably not turning that off. Okay, so that's a lot of information. All right, looking further at this, the patient, 85 years old. Oh, it's just tough. Old people, because we're going to sedate people. Old people are easily over-sedated. What's an old person? I don't know. You'll know it when you see it, because you can have a 75-year-old. He's not really old. You can have a 60-year-old, and he's an old person. Old people, they don't tolerate sedation as well as, just generally speaking. Patients from ICU, nothing new there on this particular screen. Okay, is the consent signed? Okay, you gotta have. So this is focusing on pharmacology. I could do a whole video on consent. You got, so it's on you. You bring in the patient, right. You got to get the right patient for the right procedure. You got to have consent. So where are my IVs? You have to have a functioning IV. I mean, unless you're like an emergency situation, a STEMI that doesn't have an IV, maybe the physician will give you a femoral line. But, for these elective cases, you have to have, the time to find out your IV's not working is not during the procedure. You have to have a functioning IV. If you're bringing the patient to the Cath Lab, either check the IV before they go in, or check it before you go in the room, or when you come into the room and you get on the table, before you get on the table, check the IV. Everything can come to a dramatic and bad stop if your IV doesn't work. You don't have a way to give patient, you don't have the most effective way to give patient medication. I'm not going to get in the right heart cath. Some physicians, you may be starting the right AC for the physician, and you get access for him on that. You may be doing femoral, but let's just focus on the medications. So, you do your timeout. This is just some JACO stuff about doing timeout and fire risk and implants but going on. So there is fire risk if you're not familiar with it. It's usually fire risk 1, 2, or 3. Depending on these things here. Okay, as I said, platelet count. We have a platelet count. If it's less than 150, you need to let the physician know. Hey, when you do your timeout, it doesn't have to be part of the timeout, but you gotta let the physician know. You might think, well, the physician already knows all they have. No, they don't. Maybe they do, maybe they don't. You got to bring it up to them. Hey, the platelet count is low. Are you still going to do the procedure? If a diabetic, some hospitals with glucose. I worked at one hospital, if the patient was insulin-dependent diabetic and they were NPO, they had to have their blood sugar checked every 2 hours. Not every hospital does that. Just depends on the policy at your hospital. Where I talked about the creatinine being too high, the best treatment for preventing renal failure with contrast-induced contrast-induced kidney worsening function is hydration. So pre-hydration, post-hydration. You got to have an IV for that. So you may have, the patient may have had an hour or two or more prior to coming to your procedure area, and the fluid's probably going to continue post-procedure. Creatinine clearance, like if it's less than 50, so integralin's a common, it's a glycoprotein 2B3A, it's the IV platelet inhibitor. You're cutting the infusion rate in half if the creatinine clearance is less than 50. Troponins are positive here, not necessarily meaningful in the pharmacology, but it's nice to know. Oh, female, if they're less than 50, we do an ACG, we do a pregnancy test. You're going to expose them to radiation. Radiation is not, it's not a drug, but hey, you don't want to, somebody's pregnant, you don't want to damage the fetus. So, unless they don't have, unless somebody's had their uterus removed, I typically don't go by believing people, because sometimes people are pregnant and they don't know they're pregnant. So, if I have time and the female's less than 50, I'm getting an HCG, I'm getting a pregnancy test, serum. You can call the lab. Hey, you got any blood down there? Add it on. Okay, I as a nurse can't order stuff, so you have to. The physician will give you an order for that. Get an order from the physician. So you want to troubleshoot things. You want to, it's. You might think, well, it's not my responsibility. It's not my responsibility to order lab work and to order pregnancy tests, and it's your responsibility. If you're the nurse or you're the medication giver, it's your responsibility to make sure things go as well for the patient as humanly possible. So, become part of the solution-solving apparatus in your cath lab. That's not my job. Solve problems. So if it turns into, if they got aspirin and Plavix today, if it turns into PCI, percutaneous coronary intervention, I'm going to have to confirm, did they get aspirin and oral antiplatelet, whether it's Plavix, Brilinta, Effient? If they didn't, then you're going to give it while the patient's on the table or right when they come off the table. As I said, metformin's a concern post-procedure. If the patient came in on a heparin drip, we'll get to it. If it turns into a PCI, you're going to give some type of anticoagulation. If you're going to do coronary intervention, you're going to use, most cath labs typically it's heparin or Angiomax. I did run into the doctor the other day. It's like, oh my God, does anybody still use Angiomax anywhere? They do in my world. ACB bypass surgery or asthma. All right, so if asthma, so let me back up. So what kind of medications do we give in the cath lab? We typically give things to sedate people. So you always need to know the vital signs before you give sedation. We give things to affect coagulation. So we're going to give direct or indirect thrombin inhibitors. We're going to give oral antiplatelets or IV antiplatelets. And we're typically going to give things to affect the cardiovascular system. We're going to either make the blood pressure higher or lower. We're going to make the heart rate higher or lower. Another class of drugs that we may give things to prevent or treat allergic reactions. We're going to give local. So if somebody has asthma, beta blockers, they can cause bronchial constriction. So if somebody's blood pressure is too high and they have asthma, the physician says, "Hey, give 5 a low pressure." Hey, doc, they have asthma. You want to give low pressure? No, he'll pick something else. Like I said, low ejection fraction. You got to be very judicious with your fluid administration. Potassium is normal, but I'm concerned about arrhythmias if it was abnormal. H&H, hematocrit and hemoglobin. We're going to do things that cause bleeding, like poke holes in the arteries and give anticoagulants. COVID was negative. Latex allergy, so you got to get all the latex off. You can't have any latex. Find out if your physician wants the nitroglycerin on or off when they come in. Heparin drip on or off when they come in. That may be patient specific. Okay, all of this in the patient's really not in the room. This is all the stuff you do in pre. So now when the patient gets into the room, like here's in my cath lab, most people have. I don't know if everybody does. I'm trying to remember my first cath lab, but every cath lab I've worked in, I can't remember the first one. We had a whiteboard. You'd write on the board about what's with the patient so that everybody could look up and see. In this case, it's just the kind of stuff that we write down on the board. And so now we get into the medications. Remember the 5 rights: right patient, right drug, right dose, right route, right time. You could add 2 more: right reason and right documentation. So if you follow those 7 patient rights: right patient, right drug, right dose, right route, right time, right reason, and right documentation, you won't make a mistake. That's a lot. Things are fast moving sometimes in the cath lab. Easier said than done. Yeah. All right. So this patient had an allergy, allergic allergy to shellfish. So it depends at your hospital. We're typically going to use Solumedrol. Some people use Solucortef. So we typically use Solumedrol, Benadryl, antihistamine, and Pepsid, antihistamine. Solumedrol is a direct steroid. So this is stuff that prevents an allergic reaction. The Solumedrol, we typically do 125. The Benadryl is either going to be 25 or 50 IV. It does make people sleepy, so you got to be careful of that. Take that into consideration in your sedation. And Pepsid, usually 20 milligrams IV push. Here. So if somebody has an allergic reaction, so if they break out in hives or they have some itching, you typically use Benadryl, Solumedrol, Pepsid. But they started getting into respiratory compromise. I've only had to do this one time in my entire. I've been doing this for like 35, 36, 37. Somewhere between 35 and 39 years. One time I had to give epinephrine IM for an anaphylactic reaction. Epinephrine, 0.3 milligrams undiluted IM. In a 1 cc syringe, give it every 5 to 15 minutes. Max dose, 1 milligram, rotate injection sites each time. When I had to do this, I work at Bartow. The pharmacist said this is the way you do it. I'm not saying that's how you do it. I'm just saying that was the advice of a pharmacist that I got. The one and only time I ever had to do this in 30 plus years. So, could you give a little bit IV? Yeah, but you may make the heart rate and blood pressure really shoot up. So, you got to be careful about that. But when you look up how to give epinephrine for anaphylactic reaction, whether it's your, like kids and bee stings and peanut butter and nuts, you got the EpiPen, you're making basically an EpiPen. Okay, so the doctor arrives, you do your timeout. Now, typically the first thing they're going to ask for sedation. So, I guess some cath labs could be different. Every cath lab I've ever been in, and every cath lab I've ever heard of uses Versed and fentanyl. So let me say this. Before, anytime you ever give medication in the cath lab, you the nurse or you the, all my life, nurses and CVTs gave medication every hospital I've worked at, except till the hospital where I work now. Only nurses can give medication. So when I say nurse, I may say nurse, but I'm talking about the medication giver. Every time before you go to give any medication for any reason, your big screen's going to be in the room somewhere. Glance up at what are the vitals? What's the heart rate, blood pressure? What's the pulse ox? You're going to do things. The sedation is going to depress their vital signs. So, and maybe that's a good thing. Maybe their blood pressure is sky high. But you need to know, like you wouldn't. Oh, their oxygen level's 88. Okay, well, did they come in and it was 98, now it's 88? Maybe they're restless because this would already be like if you gave some sedation. Maybe they're restless because they don't have enough oxygen to their brain. But I guess you could start somebody with a low pulse ox, before the case starts. That certainly happens. You got to be very careful. Well, one, you got to get an accurate set. Some people want the set taped on the finger. We tape ours on the finger because the little thing, the little clip on the ear, sticker on the forehead thing, sometimes they don't work so well. The ones that get taped to the finger, but people have, if they end up having cold hands because they have low blood pressure and the room's cold, you want accurate vital signs. You want an accurate heart rate. You want an accurate blood pressure. You want an accurate, sometimes it's hard to get accurate respirations depending on where your leads are. Patient's covered up, the room's dark, you can only see their face, hard to see their color. But you got to do it. You got to get a set of vital signs before you give medication. And let me say this too. When the patient comes in the room, you need to get them on the table and you need to get a set of vital signs. Most people have like a general rule. I need a set of vital signs within 10 minutes of arriving to the room. Now, some people may watch this video and go, 10 minutes? Oh my God, we get them in 5 minutes. Okay, great. But some people, don't take your time. You need a set of vital signs. You just look horrible. It's like you get your first blood pressure. Or you get, and the blood pressure is 75. You get your first pulse ox and it's 82. How long has the patient been in the room? I don't know, 15 minutes, 18 minutes. It take you that long to get your set of vital signs? You certainly need a baseline before you start giving any medication. Get them on the table, get a set of vital signs. So when the doctor arrives, if the patient's stable, you're going to give Versed fentanyl. So he'll tell you how much to give. There's that. There's information about fentanyl. Narcan's a reversal agent, so you have to know how to do that. Versed and the reversal agent is Romazicon. You have to know how to do it. If you're going to give fentanyl, you have to know that Narcan reverses it. And you're going to give Versed, you have to know that Romazicon reverses that. Dipropan's on there just because it's on the sheet. So by the way, this is the book. So I have a book. In every cath lab I've ever worked in, I have a cheat book. Like, hey, we're going to do FFR. How do we mix up an adenosine drip? Hey, we're going to give something intracoronary. If you have to dilute it, by the way, that's when mistakes are made. If I have to take a drug and I have to dilute it, and then especially if you have to take that dilution and dilute it one more time, that's danger time, danger time, danger time. That's when mistakes can be made. I will have my own book. I mean, it should be a hospital-approved book. I brought this book over from another hospital Anyway, you got to have a book. So, I've been doing this almost 40 years. I still go to the book. If I haven't given something like we do a lot of IFR. We don't do a lot of FFR. So if it's like, I got to go mix the adenosine drip because we don't do it a lot. I'll go look it up. I have to go mix something up. Like we don't hardly ever use, I don't know, like we don't use a lot of cardine intracoronary. If I haven't given that in 5 or 6 months, I will go look it up. I teach pharmacology. So if the teacher who teaches pharmacology and the nurse has been a nurse for almost 40 years working in a cath lab, I'll go look it up. And I have no problem looking it up. And I'll tell you, hang on just 1 second. Let me double check myself. Go look it up. If you think that, that's a sign of weakness or that's something I should know, I mean, I feel like you look up something every single time you give a medication. It's like you just gave that medication last case. But I'm saying, if you haven't done something in a while, look it up. You need a book. If you need this book, I'll send it to you. I'll email it to you. You got to have a book. All right. So Brevitol, this is not so much for the cath lab, but when we do our TE cardioversions, one hospital where I work, we use Brevitol. Another one where I worked, we use etomidate. You can't give the Brevitol etomidate. The physician has to give it. It's for deep sedation. By the way, in the cath lab, we're doing conscious sedation. But the Brevitol, that's a little different. So it's getting out of the cath lab. Okay. And what do you check before conscious sedation? You check the vital signs every single time. If you're going to give something that's going to affect the vital signs, so like if you're given local, the physician's given local, okay, well, I don't really care what the vital signs are so much then. But if you're going to give medication that affect the heart rate or blood pressure, and sedation will do that, you need to know what the vital signs are before you give it. So we have a decent set of blood pressure there. Okay, and so by the way, oxygen's a drug too, by the way. Okay, just for your own information, 1 liter of oxygen, 24%. 2 liters, and then you can go up 4% each time. 2 liters is 28, 3 liters is 32. When you get up to 6 liters, it's 44%. Usually when you get to like 6 liters, nasal cannula, then you got to switch to some type of mask. A non-rebreather, a Vini mask, once you get past 6 liters, that's a lot of oxygen just blowing up somebody's nose. So it's simple mask, partial rebreather, non-rebreather, Vini mask, BiPAP, intubation. Not a complete list. But oxygen's a drug. Respiratory problems. By the way, never hesitate to call a respiratory therapist. Never hesitate to call rapid response. I'll call rapid response on a heartbeat. Okay, so you're going to work in a cath lab. You're going to be 1 circulator. You're going to have 2 circulators. Most cath labs, when I talk to people, it's about half and half. This is the first lab I've ever worked in where I have 2 people circulating. Oh, it's so nice. Oh, thank you. But it's safer. It's safer because Jaco says if you're going to give conscious sedation, that should be your one and only responsibility, is to monitor the patient. Well, most every cath lab I've ever worked in, it's rare that you work in a cath lab. Everything you need is in that room. So a lot of cath labs have storage rooms in the middle of the cath lab that all people get stuff from. And so if you're the only circulator, I guess the recorder could go get supplies. But every hospital I've worked at that you had to get supplies out of the supply room, it was the circulator that would have to leave the room and go get the stent or the balloon or the whatever it was that you needed. You can't monitor the patient if you're not in the room. So I'm a strong advocate of having 2 people circulate a case. You can do it with 3. I did it most of my life until just a few years ago with 4 people. It's like, oh, this is so nice. But even with 2 people, I'll call rapid response. If the person I'm circulate, they're doing something and the case is deteriorating, and I have, if I need to do, anyway, don't hesitate to call a rapid response. Don't hesitate to call for help. All right, lidocaine, good gosh. The lidocaine is going to be 1 or 2%, with or without epi, so it's almost always going to be most cath labs without epinephrine. If you're doing pacemakers and implants, it's typically with epinephrine, but it's whatever the physician wants. Okay, so nitroglycerin, one of the most common drugs in the cath lab. You could possibly give it sublingually. You could give it IV. Physicians will give it IA for radial cases. Physicians will give it intracoronary to dilate the coronary arteries. Patients may come on it with a topical, or there's transdermal as well. So a lot of ways that nitroglycerin is used in the cath lab. So intracoronary nitro, this is one of the dangers, if you have to dilute. So most pharmacies, I don't know what people are doing around the country. Our nitro comes 100 mics per cc. By the way, when you're scrubbed into the table, or people that most people want to get everything on the table to 100 mics per cc. The nitro, the cardine, whatever it is you're giving, the verapamil, if you can get it to 100 mics per cc. I have worked in a lab where we had nitro and we had to dilute it twice. That's just, that was one way of doing it. So, this was from the hospital. This was how we diluted our nitroglycerin. So, it's so cheap. It's a single dose vial. You're supposed to drop your nitro and then throw the whole bottle away. But anyway, 100 mics per cc. Anytime you're taking a drug and diluting it, especially if you're doing that double, and then you're taking part of what you diluted it and then adding 9 more cc's to it, that's the time mistakes are made. That's the danger time. All right, so on this thing, when diagnostic cath is underway, you'll typically get an opening AO pressure. By the way, of course, people have the TUI open, the cath, you may have dampening ventricularization, but if you have an A-line, compared to a cuff blood pressure, the A line should be the pressure that you're going by. But because 2E's copilots are being open and closed, and you don't always have an accurate blood pressure up there. But if you're having blood pressure problems and your A line is up there, go by the A line. Also, a lot of cath labs, you may take blood pressure in both arms before the case starts. So if one arm is significantly lower, well, that's the arm you're not going to use. So if my right arm has a blood pressure of 120 systolic, and my left arm has a blood pressure of 90 systolic, I have some type of blockage. That's what that means. I have a blockage in my arterial system. You're going to use the right arm. You're going to use the higher arm blood pressure. You can go to legs. Legs, all the time we use blood pressure in the leg. The blood pressure in the legs, you have peripheral amplification. That's normal. It normally runs a little higher in the legs than it does in an arm for a cuff blood pressure. So if your blood pressure is high or low, this is the time you may be giving medications to affect that. So what meds, for blood pressure? All right, what do you want to avoid? So Vasotec is an ACE inhibitor used to lower blood pressure, but it can worsen renal failure. So if somebody comes in with a high creatinine or low creatinine clearance, and the physician orders Vasotec, hey, the creatinine is 1.8. Do you want to use Vasotec? They'll probably, oh, thanks. They'll pick something else. But Vasotec's a common drug to lower blood pressure. Apresilene, common drug. It's a smooth muscle relaxer to lower blood pressure. Everybody can take apresilene. I mean, unless they have an allergy to apresilene. Labetalol. Labetalol is really, it's an alpha and a beta blocker. I've seen people go, oh, they have asthma. Let's give labetalol. Okay, well, it's really an alpha and a beta. It's an alpha and a beta blocker. So you may not use it if they have asthma. Lopressor, metoprolol is a beta blocker. So very common drug, especially in anterior MI. But you typically are avoiding beta blockers in people with asthma. Nitro, everybody can get nitro. The problem is it gives people a headache, gives the patient a headache. If people have nitro paste on their skin, you got to wipe it off. You wear gloves. You get that on your hands. It dilates your blood vessels in your head. Bad headache. So there's information about low press or beta blocker. There's labetalol, Normidine. It's a beta blocker. Hydralazine, apresilene. Vasodilator, safe drug. Hydralazine, apresilene, safe drug. Vasotec or enalapril, the ACE inhibitor that you want to avoid with bad renal function. And there's a breakdown. I'm not gonna read the whole thing to you, but there's that information. So once you get the blood pressure under control, so this is an example of somebody having a high LV-EDP. So without getting into hemodynamics, a normal LV-EDP left ventricular end-diastolic pressure is 6 to 12. If it's low, people are going to get fluid because they're dehydrated. If the LV-EDP is high, and in this case, if this is 10, 20, 30, 40, 50, so our LV-EDP is 0, 10, 20, 30, and that's 40, so I don't know, 32, 33, 34. And they're really fluid overload. So then you're going to give some type of diuretic, typically almost always Lasix, could be Bumix. But, you give Lasix and they're on the table and the case is going on, they're going to pee. Unless they have a Foley in, but most people don't seem to have Foleys these days, they're going to pee. And you can't be doing a case and put them on a bedpan to pee or put a urinal up in there. They just have to be incontinent. So what could you expect a doctor order with elevated LV-EDP? Well, diuretics, no extra fluid. There's Lasix, there's Bumix. So in this example, and now the angiogram, we took an angiogram of the RCA, and we got a big old blockage. So it's going to turn into a PCI. So is this a heparin doctor? Is this an Angiomax doctor? When was the last time they got aspirin and oral antiplatelet? Do you need an IV 2B3A, the glycoprotein 2B3A, which is integralin? Some people may use Aggrastat. Reapro's not even available anymore, I don't think. So this comes into the intervention. So it turns into an intervention. It's like, give me this guy. You need an inflation device. You need a wire. Probably going to give more sedation. And you got to give an anticoagulant. So the anticoagulant, what's the time? Heparin's relatively easy. It's just a bolus, and then you're going to check an ACT at some point, hopefully. A bedside test, activated clotting time, ACT. Or you're going to give Angiomax, which you have to reconstitute, put it in the bag, drop the bolus, give the bolus, hang a drip, a little more to it. And the ACT doesn't really measure the effect of Angiomax. So I think it's a good idea to check an ACT because in Replace 2, the clinical trial that brought Angiomax for FDA approval, if the ACT was lower than a certain level, you rebolused with a lower dose of Angiomax. But it also tells you, like, if you gave your Angiomax to an infiltrated IV, the ACT is going to be normal, and then if your ACT is like normal and you gave Angiomax, so a lot of people don't even check an ACT, which I don't think is best practice. And I used to sell Angiomax. So I've been a nurse for a long time. I used to work in the industry. I used to be an Angiomax, as a pharmaceutical sales rep. And we would encourage people to check an ACT. So the critical time that you give your heparin or your Angiomax is before the coronary wire starts going into the coronary artery. So if the PCI may start, and there's not 50 things, but there's like 4 or 5 different things they're asking for at one time. And you can't do 4 or 5 things simultaneously, but you've got to get the base anticoagulation in before the coronary wire goes into the coronary artery. Okay. The add-on stuff, the integralin, the aggrastat, you can do that after the wire's in the coronary artery. A lot of people will add that on if they didn't get the best result, or they're afraid their stent's going to clot off. Maybe that's getting added on. But here, like if you're getting this, they're called glycoprotein 2B3A because that's the receptor on the platelet that they affect. That's when, if the platelet count's less than 150, you may say, hey, are you sure you want a 2B3A? Because you're going to be a high risk of bleeding. Integralin is renally adjusted. The bolus will stay. The integralin is typically a double bolus and infusion for 12 hours. And if the creatinine clearance is less than 50, you're going to cut the infusion in half. I'm sure your Cath Lab has an integralin infusion chart. You look up the weight. I don't like the weight in pounds being on there because sometimes people read the pounds and they get the dose wrong. The weight in kilograms. Every hospital I go in, talk about the patient's weight in kilograms. Look up the weight in kilograms, see what the bolus is, see what the infusion is. Here's the information about anticoagulant. Here's the information for heparin. The nice thing about heparin, it does have a reversal agent. There's protabine sulfate, Angiomax. This was the one kind of bullshit thing that I did not agree with the company. They said it was naturally reversible. Well, all drugs are naturally reversible. It had a half-life of 25 minutes. So most drugs are gone from the body in 5 half-lives. So with Angiomax 25-minute half-life, if you wait 5 half-lives, that's like 5 minutes short of 2 hours. Angiomax, if you have normal renal function, Angiomax is gone. Most people, the ACT doesn't accurately reflect. So most people do heparin, a time-based, well, if you're doing femoral, time-based sheath pull. When the ACT gets below a magic number, typically like 180 or 170, less than 180, then you can pull a femoral sheath. Angiomax is when 2 hours after the drug was turned off, you can pull a femoral sheath. Everybody takes their radial sheath out right away. Diagnostic cath, PCI, because you can put some type of Terumo band. I mean, that's the name of a company. Put some type of compression device. Very easy to compress the radial artery. But then you wait a couple of hours before you start letting air out if the patient got heparin or Angiomax. But there's Angiomax about bivalirudin. You have to reconstitute it. You have to give a bolus. You have to hang a drip. So if your physicians use that, you have to learn about that. Lovenox. it's always like, oh, somebody knows, they know somebody who had a friend down in like Miami and they use Lovenox in that Cath Lab. I've never been anywhere, and as an Angiomax rep, I went all up and down one particular coast of Florida, and I've never seen anybody use Lovenox in the Cath Lab. Hey, if you not if you know of somebody that used it, but if you've ever been, comment in the description below. I've just never seen it, and it's real common. Like if you're gonna, I'm not even gonna get into Lovenox, but there's some information about Angiomax. It can be adjusted for dialysis dependent, and if you have severe renal failure, we went back and forth in the company about physicians can do what they want. I would just, hey, if you have problems with your renal function, just use heparin. Some people say, well, we're not using Angiomax anyway because it's way too expensive. Thousands of dollars compared to pennies. All right, so what's the magic moment that the base anticoagulant has to be given before the coronary wire goes into the coronary artery? So the recorder now, your case is going, hey, the SaO2 is 85%. What do you do? All right, well, you put them on oxygen if they're not on, but most people are already on oxygen, or you may increase the oxygen. But if they're COPDers, that's a double-edged sword. You and I breathe because our CO2 levels get high, not because our oxygen level is low. But COPDers live with a high, chronic high CO2 levels. So they breathe because their oxygen level gets low. So if you give them oxygen, they could potentially stop breathing. Double-edged sword. So if the SAT's low, is the pulse ox on their finger correctly? Give them oxygen. Are they over-sedated? Stimulate them to breathe. You may have to open their airway. Typically taking the pill out is the first thing you do to open up the airway, but you may have to do a head tilt, jaw thrust, chin tilt. You're certainly not going to give more sedation if you're desatting, and you may have to reverse. So Narcan reverses fentanyl. Fentanyl's a narcotic. Narcan in. Narcan reverses narcotics. Fentanyl. Romazicon reverses Versed. Which one do you give? Well, whatever sedation if the last thing you gave was Narcan, then you give fentanyl. If the last thing you gave was Versed, give Romazicon. All right, so now they're going into VTAC or Torsades here. We have everybody on defib pads. So I know that's not medication, but we have everybody on defib pads connected. Every cath, diagnostic cath, PCI, every heart cath, we have them on defib pads. You may say, you go through a lot of defib pads. But you're going to have to run in there shock. Hey, I just did it, well, it wasn't this week, it was last week. Or was it 2 weeks ago? Doesn't happen a lot, but it's like, oh, time is of the essence when somebody's in VFib or VTAC without a pulse. It's the prudent thing to do. Put your people on defib pads. It could be for, if the catheter was in the LV or the RV, maybe you're going to give antiarrhythmics after you shock them, get them back, or if it was a catheter, they pull the catheter out, and maybe they have runs of VTAC and they go away. But, you may give lidocaine or amiodarone. Those are the two common antiarrhythmic drugs. If oftentimes working in the RCA, people Brady down, the heart rate goes low. You may end up putting a temporary pacemaker in, knowing that you're going to do, angiojet, or you're going to do some invasive thing in the RCA, or you just may have to have atropine close by, atropine to increase the heart rate. Magnesium sulfate, you don't give that a lot, that's for torsades. Adenosine or adenocard, you're going to use that for FFR. There's a whole way you mix that up. So you can give it intracoronary, you can use it, this is just how we mixed it up at our hospital for FFR. Using it for SVT or PSVT, IV push, it's just not something you typically are doing in the cath lab. So this physician, they ordered integral embolus. It's hazard, it's an IV antiplatelet. Hazardous in people with, potentially hazardous in people with a platelet count less than 100. Reapro, I don't think it's commercially available anymore. Yeah, Janssen no longer making Reapro. So there's information about integralin. Aspirin, you're going to give aspirin all the time with PCI. You're going to give some type of oral antiplatelet, either Plavix or Effient. I don't really see Effient, so I don't know if people are still giving Effient. Plavix or Brilinta or Ticagrelor. I used to sell Brilinta too, by the way. So post PCI, people are typically, if they didn't get aspirin or an oral antiplatelet, you're getting that before you get out of the cath lab. The physician just wants to make sure it's been given. Oh, blood pressure drops to 70/40. You got to make sure that they came in on nitro. Make sure that nitroglycerin is off. So drugs that you're going to use to raise blood pressure: dopamine for an IV infusion, dobutamine more of a heart failure type thing. But the one most everybody goes to, neosynephrine or phenylephrine. You're going to give this stuff IV push. So you need to learn about that. Ooh, it comes pre-mixed now where I work. This was one of those drugs that we had to dilute at one. I'm not going to say which hospital, some other hospital in the past. Guess what? Something didn't get mixed right. So anytime you have to take something and dilute it, danger, 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 something you want to avoid. So hopefully something your pharmacy has stepped in and said, we're putting a stop to you guys diluting your medications. But there's probably still something you have to do. Levophed is another drug, or norepinephrine that you may use to raise blood pressure, or epinephrine drip. I don't really see people give neosynephrine to raise the blood pressure. You may have an epinephrine drip to raise blood pressure. All right, check ACT for what reason? You want to make sure that a lot of people want to do it. Some people, they put a timer on. They're going to check an ACT 10 minutes after bolus. Most people want their ACT. They have a magic number that they want it to be. Just check with your physician if he wants it, over 300. But the ACT is specific for heparin bolus. It's still a good idea to check it on NGMX. So the doctors finished stenting the RCA. Name 2 common meds that may be given intracoronary. Well, they may give nitro, they may give cardine. And typically you want that 100 mics per cc on the table. Verapamil could be another medicine that they're given to dilate the coronary artery to make sure that it's as good looking as they can, because sometimes the wire can cause spasms, or doing things in there may cause spasms. So you may give nitro, cardine, verapamil. Cardizem's another common intracoronary drug. Some people give nipride. I don't see that a lot. We did have one physician, but then he didn't last. He was going. Nipride can be given intracoronary. So sheath pull, radial sheaths are all pulled at the end of the case. Diagnostic cases that you didn't give anticoagulation, you're typically pulling femoral and radials immediately. But anticoagulation sheaths, so whether it's a femoral sheath 2 hours after the NGMAX is turned off, or if you pulled the sheath immediately and put a TR band on, then you start letting air out. Typically, you have to check your hospital's protocol 2 hours after the NGMAX is off. That's when you start letting air out of the sheath. Start letting air out of the TR band. Most people, heparin, when the ACT gets to a magic number, this happens to be 180 for most physicians where I work. Medication, if you're going to pull femoral sheaths, you have to learn how about vasovagal. The medicines to treat that is typically fluid and atropine. When pulling sheath, blood pressure, heart rate, blood pressure, you're typically recording every 5 minutes. And just say, typically with vasovagal, you're pulling sheath and their blood pressure drops. And if you haven't, their heart rate drops, and you didn't notice it right away, they break out in a sweat, and then their blood pressure drops. Their blood pressure drops, they break out in sweat, and they say, oh, I don't feel well. Hey, I'm on call. Yes, I know I'm on call. Thank you. What do you do? So typically you're going to give fluids if the patient can tolerate fluids. If they're having vasovagal, the blood pressure drops. The heart rate drops and their blood pressure drops. You're going to give fluid, and you may give atropine, like 0.5 milligram of atropine. All right, congratulations. You survived your first PCI. So those are just some of the common, and I went through it kind of fast, but that's the common medications that you can expect to encounter when you go to the cath lab. Now there are more things that you may give. This is just a simulated overview, but I hope this helps in your understanding of what might be expected during your first diagnostic or your first PCI. All right, guys, thanks a lot. If you liked the video, hit the thumbs up. It'll help my channel. And if you found the information helpful or useful, consider subscribing to the channel. And if you do, remember to turn on notifications so that you don't miss when the next video comes out. All right, guys, thanks so much. We'll see you in the next video.